I had the opportunity to discuss this topic, which is somewhat broad and intimidating when you think about all the various lymphoma subtypes. But what I set out to cover in a short time span was the latest FDA approvals for our two most common lymphoma subtypes. So starting with follicular lymphoma, which traditionally is viewed as a disease that is coupled with very high and meaningful remission durations to the first line of therapy. Those remission durations generally get shorter with subsequent treatments, but these patients are generally looking at 18 to 20 plus years of life expectancy from the time they're diagnosed. So that means that they will see several treatment strategies over the course of their disease. So the goals of our therapy are not only to achieve meaningful remission durations, so ideally they'll have time periods where they're off therapy. We also have to keep in mind that we want therapy that will not have a negative impact on quality of life. And obviously we don't want to have therapy that's going to lead to shortened life expectancy. So as a result, there's been significant interest in looking at non-chemotherapy approaches, particularly beyond frontline. And one of the most interesting options is looking at lenalidomide-based approaches, which is an oral immune modulator, because we know the microenvironment drives a lot of the prognosis we see in follicular lymphoma and is a rational target. So lenalidomide in combination with rituximab has been studied both in the frontline setting in the randomized Phase III RELEVANCE study, where it was looked at head-to-head in comparison with chemotherapy and rituximab in high tumor burden patients. And though that was a negative study, my opinion is that lenalidomide and rituximab had a favorable efficacy profile and tolerable safety profile. So as a result, it's listed as an option in the US, recognizing that it was not superior to our chemo based off of the relevant study. But probably where it has more of a role is in the relapse setting based off of the augment study, which is a randomized trial of lenalidomide plus rituximab versus rituximab monotherapy in relapsed follicular marginal zone lymphoma patients. And there was a significant improvement in progression-free survival and even in overall survival among the follicular lymphoma cohort. So as a result, lenalidomide and rituximab are FDA approved for patients with relapsed follicular and marginal zone lymphoma, and in my opinion right now has a strong hold in the second line setting. What's also recently been approved is tazemetostat, which is an oral EZH2 inhibitor based off of a single-arm multi-center study. Interestingly, whether you were mutant or not was not part of the eligibility criteria, though retrospectively they've defined higher response rates among the EZH2 mutant follicular lymphoma cases, which is projected to be anywhere from 10 to 30% of cases. But strikingly, the median progression-free survival was not substantially different between the EZH2 wild type, which was around 11 months, versus the EZH2 mutant, which came in close to 14 months. So as a result, the FDA indication for the mutant follicular lymphoma patients is after 2 lines of therapy, but even for wild type or unknown status, it's available for patients who have no agreeable or identifiable standard of care option, and that's likely speaking to the very favorable toxicity profile. The last thing I covered was the new approval of tafasitamb, which is a naked CD19 antibody in combination with lenalidomide for relapsed large cell lymphoma patients who are not transplant candidates. So this is an interesting discussion because the treatment landscape in relapsed refractory large cell lymphoma has expanded rapidly in the last 1 to 2 years. Particularly of note, this is for patients that were otherwise facing dismal outcomes, so having more treatment options is a notable improvement. So tafasitamb is a naked CD19 antibody, and when combined with lenalidomide, resulted in quite impressive progression-free and overall survival. Notable, most of the reasons for being not a good transplant candidate was based off of age. So the study population is mostly comprised of patients in their 70s, but this now provides a treatment option for patients where they can receive treatment through their community oncologist. And again, is a notable improvement. Where I see additional chemotherapy-free options becoming available are the bispecific antibodies that are emerging as quite impressive in terms of relapsed follicular and large cell lymphoma. And then there are a number of CAR T-cell therapies that are expanding the potential application with recent approval of CD19-directed autologous CAR T for mantle cell lymphoma and anticipated approval in follicular lymphoma. So again, the time of drug development in lymphoma is becoming very attractive and complicated, but it's providing more options for our patients, which is important.